Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you Canada's brightest minds in emergency medicine from EMC Studios in Toronto. EM Cases is part of SREMI, Schwartz-Reisman Emergency Medicine Institute, the nonprofit organization dedicated to improving EM care through research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. This episode is brought to you by Easy Resus, the resuscitation assistant. This amazing app has drug dosing, equipment size calculation, treatment algorithms, all in under 3 clicks. Rapid access to life-saving critical info in a user-friendly interface. Try the app for free with the promo code EMCases or visit easyresus.com/EMCases. That's easyresus.com/EMCases. In part 1 of this 2-part podcast series on subarachnoid hemorrhage, we covered when to consider the diagnosis, why we miss the diagnosis, how to work up subarachnoid hemorrhage, the LP versus the CTA debate, CSF interpretation, and a lot more. In this part 2, with the help of Dr. Katie Lin and Dr. Jeff Perry, we'll talk about the sick subarachnoid hemorrhage patient, a totally different kettle of fish. So to kick it off, so you know what we're talking about, let's start off with a case. A 60-year-old female rolls into a resuscitation bay with a GCS of 7. She was in the midst of a heated argument with her husband at home when she suddenly developed an abrupt onset of 10 out of 10 headache and vomiting. Vitals include a heart rate of 120, a respiratory rate of 22, oxygen saturation of 87%, and a blood pressure of 210 on 140. Now, as I mentioned in part 1, while many patients with subarachnoid hemorrhage present with a headache alone, there are others who present much sicker. And with these patients, all too often, we make the diagnosis of subarachnoid hemorrhage, call neurosurgery, and just stop there. We move on to the next patient. It's kind of akin to post-intubation care. You know, we might have a challenging intubation scenario, and when we get the tube in, there's high fives all around the stretcher, but we might neglect sometimes the very important post-intubation care details. And so sometimes it might be with subarachnoid hemorrhage. Take a look at the CT, see a subarachnoid hemorrhage, and now our main goal is to get the patient out of our emergency department to a neurosurgeon, which is a good goal to have. But again, we might overlook some of the really important details of care that may very well improve outcomes for our subarachnoid hemorrhage patients. Now, before we get into the details of managing the patient with confirmed subarachnoid hemorrhage, we need to talk about the patient who is undifferentiated, just like the one I presented to you. So Dr. Lin, first, if you could briefly riff off your fantastic recent post on First 10 EM, the crashing brain, the first 10 minutes, what are the main critical priorities in the undifferentiated crashing brain patient?
Awesome, Anton. So I think when you have an undifferentiated crashing brain patient, we know that every second and every moment counts. So we want to be very organized and we want to have a plan going in. I would say that the 4 most critical initial priorities in the first 10 minutes would include, number 1, check the glucose. I think we're all pretty good at this, but it's important to remember that glucose is an important part of the vital signs for any patient with neurologic complaints, confusion, or altered level of consciousness. If you can't easily get a glucose check, empirically give an AMP of D50 and move forward. 2, perform a rapid neuro exam to identify signs of herniation or deterioration and major deficits. Again, this is not the reflex hammer and smelling salts neuro exam that we learned in med school. It's a 3-part exam that should take you no more than 10 seconds to complete. And it's comprised of GCS, eyes, and motor. That's where you need to be focusing your efforts. This is what's going to pick up the things that we care about most in the world of neurosurgery, ICU, and stroke. So GCS, what is it? And is it actively worsening from the reports you're getting from bystanders, collateral history, or EMS? Eyes, are the pupils even and reactive? Are the eye movements and alignment normal? Or is there diplopia, dysconjugate gaze, or uneven pupils? And finally, motor. Is there an obvious asymmetric weakness in the arms or legs to tip you off to a focal deficit that's major? 3 is to avoid hypotension and hypoxia at all costs and consider early airway management, especially if you have a patient who is displaying uncontrolled agitation, persistent vomiting with aspiration risk, or has a dropping or low GCS. And finally, 4, you want to get the patient to the CT scanner quickly and safely so that you can make the diagnosis, initiate targeted treatment, and activate the right consultants early on for definitive management. So consider if the airway and vital signs are stable enough for you to get the patient to the CT scanner now, or if you need to resuscitate before you send. Because trust me, you do not want to run a code or intubate at the donut of truth.
The donut of truth. I love that. So just to review there, the 4 most critical initial priorities in the crashing brain are checking the glucose. We've all been there when we have a patient who we think has a stroke, but their glucose is very low. And as soon as you correct the glucose, their stroke suddenly disappears. Number 2, the quick neuro exam, which is essentially just GCS, eyes, and motor. Number 3 are the 2 evils of any brain bleed, which is hypotension and hypoxia, which you want to correct. And then number 4 is just make sure that they're resuscitated enough to go to the CT, where it will be the donut of life instead of the donut of death. We discussed the workup of subarachnoid hemorrhage extensively in part 1 of this 2-part podcast on subarachnoid hemorrhage, and that was in the neurologically intact patient. But for the sick subarachnoid hemorrhage patient with neurodeficits, the workup is going to change a bit. There's an argument to be made that when you're sending a patient for your plain CT, just to send them for plain CT plus CTA immediately, rather than sending them for the plain CT, then them coming back to your department, reading this plain CT, and then having to send them back again for a CTA in most of those patients. Could you just elaborate on this idea of ordering a CT-CTA off the top of the bat in some of these patients and which patients you would order that in?
Absolutely. So again, the caveat that I'm just going to mention here is it's going to depend a little bit on some of the imaging protocols that you have at your center and accessibility of a combined CT-CTA from the emergency department. So in general, in sick patients with undifferentiated neurologic deficits, time is of the essence. So we know that most of the damage is completed within the first few hours and really that first hour of injury onset. So the sooner we arrive at a diagnosis, the sooner we can initiate targeted therapies and engage the right specialist consultants for definitive management. As much as we'd like to think that we can predict if an undifferentiated neurocritical patient with focal deficits is going to be ischemic or hemorrhagic in nature, the truth is that if we're only looking at clinical factors, what's their level of consciousness, how high is their blood pressure, we don't reliably predict that. That's what the literature tells us. So imaging is still our mainstay of diagnosis. And so in patients who have no ICH or subarachnoid hemorrhage on their plain CT, you end up having to go looking for an acute ischemic stroke if they have focal deficits present. And if there is an intracranial hemorrhage or subarachnoid hemorrhage on the initial plain CT, you also need to kind of go looking for causal aneurysm or vascular abnormalities. If the patient is stable and well and neurologically intact, and your pretest probability is low or moderate to begin with, you have the time to take a stepwise approach. Send them for the plain CT, come back, reevaluate, and decide if they need to go on for a CTA. But if your patient is critically ill, deteriorating, or you have a really high pretest probability with major deficits already present or a sick patient in front of you, you don't want to delay establishing the diagnosis with a stepwise approach and delays on either end going to and from the diagnostic imaging department. You want to be getting that CT followed by that CTA as efficiently as possible so you can establish the diagnosis and initiate your targeted treatments right away. So consider first-line CT plus CTA if it is readily available at your center in patients who have major focal neurologic deficits, and I'm talking vision loss, speech, or motor deficits, if they have low or dropping GCS, if there's a known pre-existing intracranial vascular abnormality, if there's a clear contraindication to LP, for example, the patient is anticoagulated, and if there's shared decision-making for delayed presentations greater than 6 hours from headache onset.
All right, that's a great list of reasons to order your CTA with your plain CT up front and just get it all over with. Excellent. That would definitely save some headache, excuse the the pun there, with both us and our patients. Dr. Perry, any comments about what type of imaging to do depending on how sick your patient is?
Yeah, I mean, I completely agree with Dr. Lin as far as if you have a patient with new neurological deficits, either global or focal, one, they need to be stabilized quickly. And then two, they need to get the appropriate imaging done in one visit to the CT scanner. We've already talked about circle of death or circle of life, however you want to look at the CT scanner, but you don't want to be spending more time in there than you need to, and certainly you don't want to have repeated visits there. You also need to think time is brain, so you need to move quickly. And in fact, in our center, many of these patients are run as stroke codes because if they've got new focal neurological deficits, even if they have a new headache, they certainly still could be in an acute ischemic stroke. And these subarachnoid hemorrhage is a type of hemorrhagic stroke. So they are interested in managing all these patients very quickly. While obviously, if it turns out to be an aneurysmal subarachnoid hemorrhage, care will shift to the critical care area and neurosurgery rather than neurology. We often do run these patients as stroke codes if they're presenting within a appropriate timeline.
Yeah, my clinical experience certainly fits with what you were mentioning, Dr. Lin, about the literature on how good or bad we are at predicting the diagnosis clinically, whether it's a bleed or not. I mean, I've had many patients with ischemic stroke who I could swear that they had a bleed, with headache and vomiting and decreased GCS. And I'm like, oh, they're a bleed for sure. And I usually tell my resident, oh, they're a bleed for sure. And then, of course, I'm embarrassed when they come back and the plain CT is totally clean and they've had a big ischemic stroke. So definitely something to think about. And just a good general reminder that certainly ischemic strokes can present with headache. Not typical, but they certainly can. You had talked from the top about saving the crashing brain, about avoiding hypoxia and avoiding hypotension. I want to zero in on those two things more carefully. So how exactly do you avoid the deadly duo of hypoxia and hypotension in the sick subarachnoid hemorrhage patient?
I think it's all about getting your vital signs early, paying attention to them, and starting your interventions empirically before you have any diagnosis. So if your patient is hypoxic, initiating your supplemental oxygen to target O2 sats greater than 94% early on, and considering early airway management like we talked about, especially if you have escalating oxygen requirements or if the patient's actively vomiting and at risk for aspiration. Keep in mind, if you have a patient who is continuing to actively vomit before you send them to CT, once you lie them supine, they're an aspiration risk just waiting to happen. If the patient is hypotensive, you need to act quickly. So consider an IV fluid bolus and early vasopressor support to maintain mean arterial pressures greater than 80 millimeters of mercury to overcome any ICP issues. And if you are planning to intubate the patient, just make sure that you have a plan in place for peri-intubation hypotension. So if possible, have your vasopressors running or available at the bedside before you start to intubate.
Fantastic. So just a reminder to our listeners that the reason why we want to avoid these two terrible things and also avoid raised ICP and all the other things that we're going to be paying attention to are because really what we want to do is to prevent hematoma expansion, prevent rebleeding, prevent delayed ischemia. We want to definitely identify raised intracranial pressure, and we want to prepare the patient for definitive management. So let's talk about all of these. So far, we've hit hypotension and we've hit hypoxemia. Let's talk next about raised ICP. So let's say you identify clinically that your patient has raised ICP, and maybe on the CT scan, the radiologist mentioned something about signs of raised ICP on the CT. What's your management strategy going to be for raised ICP in the setting of subarachnoid hemorrhage?
First, we need to remember that all we're really doing at this point is temporizing until the patient can receive their definitive management. So we are desperately buying a little bit of time to get that patient to a decompressive procedure. We can't sit back on our haunches as soon as the ICP seems to be a little bit better. So we can think of ICP management in tiered stages from least to most invasive. So tier 1, least invasive, raise the head of the bed, right? If the patient can sit up, sit them up. If they can't sit up or if they have to be on spinal precautions, at least consider reverse Trendelenburg. And blunt the pain and emesis response, because those things are going to spike the ICP and the blood pressure as well. So I tend to get fentanyl and antiemetic medications on board early for these patients. Tier 2, consider hyperosmolar therapies. Whether you're using 3% hypertonic saline at a dose of about 100 to 200 cc's for an average bolus, or mannitol at a dose of 1 gram per kilogram IV as an average bolus for an adult patient. It doesn't really matter when you look at the literature. And in a pinch, you can also give 1 to 2 amps of sodium bicarb, which is equivalent to about 6% saline solution if you have no access to your typical hypertonic or mannitol. So think about hyperosmolar therapy, tier 2. Tier 3 is intubate the patient, deeply sedate and paralyze them, and consider hyperventilation to a range of a PaCO2 of 30 to 35. But really try and do this for no more than 1 to 2 hours. Hyperventilation works because it causes vasoconstriction to limit cerebral edema, temporize ICP worsening. But if you hyperventilate that patient for longer than 1 to 2 hours, you end up actually causing more potential downstream ischemic damage from that prolonged vasoconstriction and breakdown of the blood-brain barrier. So it's really just a temporizing solution. And then tier 4, of course, is your most invasive, your neurosurgical interventions. So those are things like external ventricular drains or EVDs or decompressive hemicraniectomies. And we're going to be calling on our neurosurgical colleagues for help with those ones.
I did a few of those in the Emerge last week. I mean, easy peasy.
Easy peasy.
So I love it. The 4 tiers of raised ICP management. Simple things first, raise the head of the bed, 30 degrees. Blunt that pain and emesis response with fentanyl and antiemetics. Don't forget your hyperosmolar therapy. It doesn't really matter which one you use. Tier 3 is to intubate and deeply sedate and paralyze the patient. And if you're going to hyperventilate, do it only for 1 or 2 hours to a target PCO2 of 30 to 35. And then finally, get your drill out and drill the patients. No, I'm just kidding. Speak to your neurosurgeon for consideration of an external ventricular drain or hemicraniotomy. One of the list of horrible things that can happen to these patients with subarachnoid hemorrhage is delayed ischemia. And in the ICU literature, there's lots of debate, and there's been new guidelines that have just come out that talk about how we can prevent this delayed cerebral ischemia, because this is really what leads to bad outcomes. And even though most of these things that we can do are really in the purview of the ICU, I think it's important for us to understand first that there is delayed ischemia and that there are ways to limit it, and that we may want to consider starting those ways of limiting the delayed ischemia in the emergency department. So, Dr. Lin, could you just tell us, what do we need to know about preventing delayed ischemia in a patient who has a subarachnoid hemorrhage, who's sick in your emergency department, who might be waiting, 12 hours or 16 hours to get to the ICU? Hopefully not. Hopefully they'll be sooner. But sometimes, unfortunately, the reality is there is a delay, and we might have to start some things in the emergency department to delay the horrible delayed ischemia that may happen.
Absolutely. So first of all, let's talk about the relationship between subarachnoid hemorrhage and delayed cerebral ischemia. We don't fully understand the mechanisms behind it yet, but we think that most of it is likely due to delayed vasospasm following a subarachnoid hemorrhage. And again, usually that vasospasm occurs after 72 hours of the actual subarachnoid hemorrhage event, and it peaks at about 7 days post-subarachnoid hemorrhage. So this is very much on the radar for our ICU colleagues. Cerebral vasospasm actually occurs in about 1/3 of aneurysmal subarachnoid hemorrhages. And it tends to occur when there's lots of blood present, so high volume bleeding or high grade of subarachnoid hemorrhage. It is associated with about 1 in 5 patients either dying or having severe irreversible disability. So there is a reason that we want to prevent it from occurring. In the ICU, Oral nimodipine, so a calcium channel blocker, is used prophylactically in spontaneous or aneurysmal subarachnoid hemorrhages to prevent vasospasm. And this is dosed at 60 milligrams orally or through the OG or NG tube every 4 hours, initiated within 48 hours of the actual subarachnoid hemorrhage event. Note that we only use the oral formulation and not IV typically, because IV has been associated in the literature with increased risk of serious adverse events and death as compared to the oral version, which is guideline recommended. And oral nimodipine is actually the only medication that's guideline recommended for spontaneous subarachnoid hemorrhage to prevent this delayed cerebral ischemia. I will also point out that the benefits of nimodipine really apply only to spontaneous subarachnoid hemorrhage. It has not been proven or evidence-based for traumatic subarachnoid hemorrhage at this point in time. However, in general, I would consider nimodipine to be more of an ICU treatment rather than an ED one, unless there's a really significant delay to an ICU bed, hopefully not 48 hours, but I suppose we don't know what the future might hold. At the ED level, I think that the most important thing that we can do for our severe subarachnoid hemorrhage patients, in addition to all the neuroprotective supportive care that we're going to be providing them, is to monitor urine output, monitor volume status, and monitor sodium level early on. So especially in patients who have been intubated or have low GCS, having a Foley placed early with instructions to monitor urine output is important because these subarachnoid hemorrhage patients are at high risk for cerebral diuresis. Essentially, irritation from blood on the brain triggers cerebral salt wasting, which then draws water out with it and causes a significant diuresis, rapid hypovolemia if it's not caught early. And so this puts the patient at risk for hypotension, which we know is bad for a sick brain, and it also puts the patient at risk for cerebral vasospasm and cerebral ischemia. So get a Foley in, watch for sudden increases in urine output to indicate potential cerebral salt wasting and diuresis. Check the sodium frequently because they can become hyponatremic, and then match fluid input with output to maintain euvolemia and eunatremia as a means to prevent cerebral ischemia in the early post-subarachnoid hemorrhage phase.
Nicely put there. So just to kind of summarize, so far we've talked about avoiding hypoxemia and hypotension, and that the most important things we can do for the severe subarachnoid hemorrhage patients is to monitor urine output, monitor sodium level, and maintain euvolemia. And all these things will help prevent delayed ischemia. And it's good to know that nimodipine is an evidence-based treatment for subarachnoid hemorrhage for preventing delayed ischemia. You know, we might just want to ask our neurosurgeons for those patients who are sitting in our emergency departments for way too long if they'd like us to start them on nimodipine in the emergency department. Hopefully they'll be in the ICU in time for them to need their nimodipine. Dr. Perry, any comments about avoiding hypoxemia, about avoiding hypotension, about preventing delayed cerebral ischemia? Any additional comments about that?
Yeah, so I think Dr. Lin's covered it quite well. The only thing I would just add on is the delayed vasospasm is extremely important to the subarachnoid hemorrhage patient. Almost a quarter of the people who die because of subarachnoid hemorrhage, it's actually due to vasospasm, not the bleeding. It's actually the delayed vasospasm that ends up killing them. And of survivors, about a third of people will actually have permanent deficits, again, due to vasospasm. So it is something to be very concerned about, and it does need to be managed very carefully. But it is tricky for us as emerge doctors to intervene because this typically will happen days later. So certainly doing everything we can to optimize the brain as it is in the emerge is very important. And then a lot of the other care for vasospasm will happen downstream. And then the one other thing I would just make sure people remember is we talked about it in the earlier podcast, but a lot of patients can get rebleeding. So anytime your patient suddenly deteriorates, make sure you do consider that, did this patient actually just rebleed? And now their situation's actually catastrophically worsened. And that will require us to be much more aggressive in terms of their care.
And now a word from one of our sponsors, EZ Resus, the resuscitation assistant. Did you know that Easy Recess is brought to you by a nonprofit organization dedicated to improving care in resuscitation? This means that every dollar from your subscription goes to improving Easy Recess. But not only that, thanks to your contributions, Easy Recess can be made affordable for healthcare workers in developing countries so that they can also deliver the best care possible to their patients. If you want to help them in their mission, download Easy Recess and use promo code EMCases to get your first 2 months free, or visit easyrecess.com/EMCases for more details. I want to talk a little bit about seizure prophylaxis because many of these patients with big subarachnoid hemorrhages will end up with a seizure. And I understand that there's some suggestions based on the newest 2023 guidelines on subarachnoid hemorrhage. When is seizure prophylaxis indicated for these patients with subarachnoid hemorrhage? Dr. Lin?
So I'm going to truncate a little bit here. It's usually not indicated, but sometimes it is, according to the guidelines. So if you look at the AHA guidelines from 2023 on subarachnoid hemorrhage, they say that prophylactic anti-seizure medication should not be routinely used, but can be considered in high-risk patients. And they list 5 conditions. So first is ruptured middle cerebral artery aneurysm. Second is intraparenchymal hemorrhage associated with the subarachnoid hemorrhage. Third is high-grade aneurysmal subarachnoid hemorrhage. Fourth is hydrocephalus. And fifth is cortical infarction. Now, I'm going to give you just a sort of simplified 3 criteria approach that I actually use at the bedside to decide about this. So when would I personally consider adding anti-seizure medication to a patient's case? Well, 1, if they're having recurrent seizures or non-immediate seizure activity, and what I mean by that is an isolated seizure that's self-limiting at the time of the subarachnoid hemorrhage event itself does not necessarily warrant empiric seizure medication. However, if the seizure occurs after the initial event, so an hour later or more, or if there's a second seizure event or the seizure is persistent, then seizure medications are likely warranted. Second, if there's lots of blood, low GCS, or the patient is intubated and you're having difficulty determining their neurologic status, you can't monitor them as well, that's another time where you might want to consider it. So more blood equals more brain irritation equals more seizure risk, and low GCS or intubated equals less ability to detect seizure and higher risk for subclinical or non-convulsive status epilepticus if you don't have access to a continuous EEG. So I would strongly consider that for patients with GCS less than 8 or who are intubated. And I would potentially consider it with a low threshold if you have a patient who has a GCS of less than 12 or a GCS that's declining. And finally, third, I would consider it for an unsecured ruptured aneurysm with evidence of ongoing bleeding on imaging. So while you're waiting for that aneurysm intervention or securing with our neurosurgical colleagues, this patient is at high risk for bleed expansion and increased seizure risk. So it would be reasonable to consider prophylactic anti-seizure medication in that particular situation, which can then be discontinued once the aneurysm is secured.
Suffice to say that the sicker the patient, the more you should consider using seizure prophylaxis. And this might be a question that you ask the neurosurgeon as soon as you get on the phone with them when you make the diagnosis. Let's say you do use anti-seizure medication. Which one would you recommend? Because my understanding is that the guidelines are pretty clear about which anti-seizure medications not to use.
Absolutely. So if you look at the 2023 guidelines, they specifically make mention that phenytoin or dilantin use is associated with higher morbidity in this particular patient population and should be avoided. But I did just want to kind of mention that it's hard to know if this association is correlation or causation because patients who have seizures with subarachnoid hemorrhage are more likely to get anti-seizure meds, but those are also the patients who have a higher overall mortality risk. And so again, correlation versus causation here. However, in general, if I find myself in a scenario like the ones I've previously outlined where I'm considering an anti-seizure medication in this patient population, I'd probably choose levetiracetam or Keppra. And the loading dose for that would be 20 milligrams per kilogram, which is approximately 1.5 to 2 grams IV in the average adult-sized patient. And that can be infused over 5 to 15 minutes. It's generally pretty hemodynamically stable with minimal side effects. So that's typically my go-to of choice.
As we've been hinting at, the 2023 AHA guidelines for the management of patients with aneurysmal subarachnoid hemorrhage has come out, and it states that the goal of treatment should be complete obliteration whenever feasible to reduce the risk of rebleeding and retreatment. So, Dr. Lin, can you give us a sense of what happens to these patients once they're admitted to the ICU in terms of preventing rebleeding and, again, vasospasm and delayed ischemia? We've already talked about nimodipine. They'll probably be getting that. There's pretty good evidence for that. What about rebleeding? I mean, there's the obvious things like keeping the blood pressure at a reasonable level. What do the guidelines tell us about preventing these delayed complications?
Absolutely. So it kind of breaks down into neuroprotective supportive care, which reduces your rebleeding risk, and then targeted neurosurgical interventions for complete obliteration, as we talked about in the guidelines. So neuroprotective supportive care, continuation of what we're already starting in the emergency department. That's going to be a term that I call euboxemia, essentially. You're getting all of the little check boxes in your vital signs within the normal range. So that's your temperature, glucose, blood pressure, oxygen, CO2, and volume status. Most of the time, these patients are going to have an arterial line placed quickly for monitoring to avoid and rapidly respond to swings in blood pressure, because blood pressure can be quite volatile within that acute phase. The ICU team is going to continue managing ICP, as we talked about before, with all of the various interventions that we had mentioned and touched on. And then careful neuromonitoring for signs of that delayed cerebral ischemia, which again typically starts after about 72 hours and peaks at 7 days post-aneurysmal subarachnoid hemorrhage. So that's going to be your frequent neurovital checks, repeat neuroimaging if there's any signs of clinical worsening, which again could be due to vasospasm or could be due to rebleeding of the aneurysm, as Dr. Perry pointed out. And then prevention of delayed cerebral ischemia and vasospasm, like we talked about before. So volume monitoring those sodium levels, looking for that cerebral salt wasting, maintaining euvolemia, eunatremia, and layering in your nimodipine. For targeted surgical interventions, for the aneurysm itself, there are a couple of different options. There's endovascular procedures like coiling or embolization. There's also neurosurgical procedures like clipping or resection of the aneurysm itself. And then there's also a procedure called flow diversion, where you actually create a bridge to bypass the flow past the aneurysm. All of these surgical approaches are typically going to require hemicraniectomy for access. So it's going to really depend on size, location, patient factors. And those are things that your neurosurgeon is going to look at to determine the best approach. And then, of course, there's actually neurosurgical interventions for obstructive hydrocephalus that can accompany subarachnoid hemorrhage. So when you get a big subarachnoid hemorrhage that decompresses into your ventricles, blood gets stuck in the cerebral aqueducts and basically clogs it up and prevents CSF drainage. So then you start to get this buildup of CSF, and that's what causes your obstructive hydrocephalus and raised ICP. So for that particularly, our neurosurgical colleagues will usually consider something called an external ventricular drain, or an EVD. And if you've ever seen this done, it looks absolutely trippy. But basically, your neurosurgeon does it at the bedside. They have this incredible spidey sense of where your third ventricle is, and they just go for it. And so this is a catheter that's placed into the third ventricle to drain CSF, decompress the ventricles, and it actually gives you some ICP monitoring at the same time.
Wow. Everything an emergency physician would want to know about neurocritical care and neurosurgery in 3 minutes. That was great. Thank you, Dr. Lin. I want to talk a little bit about prognostication. Is there an easy way to prognosticate these patients? I mean, I'm always leery of telling the family what the prognosis is. I mean, my understanding is that if their GCS is really, really low at the bottom, like 3 or 4, that there's very little chance of survival at all. And I think that's important for families to know. Besides that, is it reasonable and safe for us to provide any prognostic information for the patient's family?
I think that neuroprognostication in general is always a little bit tricky and should be approached with caution. There are different subarachnoid hemorrhage grading scores that exist that predict mortality following especially an aneurysmal subarachnoid hemorrhage. And I would say that among those, the most widely used and well-known, and also the simplest, is the Hunt and Hess score. So the Hunt and Hess score is a 5-grade scale for subarachnoid hemorrhage severity. And an easy way to grade it is to really look at the GCS and severity of your symptoms, with GCS being the most important proxy, like you mentioned, Anton. So a grade 1 Hunt and Hess is a GCS of 15. This is a neurointact patient with mild symptoms, mild headache or neck stiffness, no neurodeficits. Even within the grade 1 category, mortality is still up to 30% in these subarachnoid hemorrhage patients. Grade 2 is a GCS of 15, so neurointact, but moderate or severe symptoms. So severe headache or neck stiffness, maybe you're starting to see some cranial nerve deficits creep in here, and mortality increases up to 40% here. Grade 3 is where you start seeing drop in GCS. So this is patients who have a GCS of less than 15. They are confused or somnolent, and they have moderate to severe symptoms. So again, severe headache or neck stiffness, or it's difficult to assess because of their level of consciousness. And now you're starting to see more neurodeficits, like your motor deficits. Here, your mortality is going to be in the 50% range. And then you get to grade 4. So these are your GCS less than 8 patients with severe symptoms and deficits where mortality jumps up to 70%. And finally, grade 5, which is the most severe score, is a GCS of 3 to 4. These are essentially your comatose patients who really just have posturing, whether that's decerebrate or decorticate, or they're completely flaccid. And here at a grade 5, you have a mortality of 90%. So I think it's important to have a general sense of how the mortality correlates with your initial presenting GCS. The one caution that I will put out there is that if you have a patient who has GCS that's mostly depressed because of obstructive hydrocephalus, so it doesn't take a lot of blood in the ventricles to clog up the cerebral aqueducts and cause an obstructive hydrocephalus that raises your ICP and causes herniation. If it's mostly obstructive hydrocephalus, then that is potentially a correctable and survivable condition with appropriate intervention with an external ventricular drain. And you can sometimes see patients go from a GCS of 3 up to 13 or 14 immediately after EVD placement. That is not quite the same entity as you're seeing a ton of blood all over the rest of the CSF spaces. That's a different type of patient. So I think just in general, caution around neuroprognostication here. Even though we have this great grading scale, there's nuance to it that I think is important.
I just want to highlight there how serious of a disease this is. I mean, even the patients that have very mild symptoms have a mortality rate that's up at 30%. That's, I think, really important to know, especially when we're counseling families, because I think sometimes, and I've heard this from intensivists before, that the really nice emergency doctor told the family that everything was going to be fine. And I think this is an example of a disease process where we really need to let the family know that this does have a very high mortality rate. And if their GCS is less than 15, like you said, they have a 50% chance of dying. I think it's important for us to understand that. Dr. Perry, any comments about prognostication for these subarachnoid hemorrhage patients?
A lot of those patients, as you say, they only have a survival rate of 70%. Again, a lot of those patients get into problems with either early rebleeding or the delayed vasospasm is just horrible. And we have to keep subarachnoid hemorrhage in mind too. When you get somebody who comes in with an ischemic stroke, who then you kind of hear, well, yeah, they had this really horrible headache about a week or a week and a half ago. That patient may actually be having vasospasm secondary to a recent subarachnoid hemorrhage. And so you need to think about that, because if we give TPA in that patient, that could actually be catastrophic. So we have to think about that. Obviously, most patients that come in with an ischemic stroke don't have that history. But if you do get that kind of story, to take pause and think about that a little bit and make sure that the neurologists or the emerge physicians, such as Dr. Lin, who are considering thrombolysis, know that feature so that can sort of enter into their decision-making as far as whether or not thrombolysis is appropriate.
Good point. All right. Dr. Lin, could you just summarize for us your acute management of the sick subarachnoid hemorrhage patient? We've covered a lot of detail here, just so that people can kind of remember in the heat of the moment when they've got this sick subarachnoid patient who has a high mortality right in front of them. What are sort of the key take-home summary points?
So I'll take you through basically controlling bleeding, limiting bleeding, and neuroprotective supportive care here. Point number 1, reverse anticoagulation or coagulopathy if present. So if the patient is on warfarin or a direct oral anticoagulant, think about your PCC 2,000 units empirically early on in that patient. 2, manage your blood pressure and avoid hypotension and hypoxia. So depending on what guideline you look at, you're going to see slight variations in blood pressure targets. My recommendation to keep it simple: systolic blood pressure less than 160, mean arterial pressure less than 110, and avoid hypotension. So keep that MAP or mean arterial pressure greater than 80. If the patient is hypertensive, my first line for blood pressure lowering therapy is fentanyl and antiemetics first. Then think about your other agents like labetalol or hydralazine. And avoid nitro-containing medications for blood pressure lowering if possible, because these actually cause cerebral vasodilation as well. So while your blood pressure looks better on the blood pressure cuff, your ICP may actually be worse. 3, keep the patient euvolemic, IV fluids as needed, and monitor your urine output early on for signs of cerebral salt-wasting diuresis that's going to put the patient at risk for hypotension and vasospasm. 4, there is no defined or evidence-based role for tranexamic acid in spontaneous subarachnoid hemorrhage. Definitely consider it in the appropriate context for traumatic subarachnoid hemorrhage, especially if there's polytrauma present, but there is no role for it in a spontaneous or aneurysmal subarachnoid hemorrhage, not at this time at least. 5, there is no acute indication for empiric anti-seizure medication for prophylaxis, but do have a low threshold to give it if there's evidence of recurrent, delayed, or persistent seizures, if the patient has an actively bleeding unsecured aneurysm, if there's a large volume of subarachnoid hemorrhage blood, if they have low or dropping GCS, or they're intubated and you're unable to elicit a reliable neuroexam, but do this in consultation with your ICU and neurosurgery colleagues. And that brings us to the final, number 6, involve your consultants early, whether that's stroke, neurology, neurosurgery, interventional radiology, or ICU, depending on your local clinical context and resources.
All right, wonderful. So just to review that quickly, reverse any anticoagulation or coagulopathy. Your magic blood pressures are going to be a MAP between 80 and 110. Maintain euvolemia to avoid that vasospasm. Give empiric antiepileptic medication only for a subset of patients. You'll probably want to speak to your neurosurgeon about which patients you're going to give it to. It's certainly not routine, and call your friends. You're going to need help with these patients. It's very exciting. The speaker lineup is confirmed. I can't wait. Yes, registration for the November 2024 International Online EM Cases Summit will open on July 16th, 10 a.m. Eastern Standard Time at emcasessummit.com. Not only will your favorite EM cases guest experts be giving high-yield talks, but we'll have small group virtual simulation sessions. We'll have a rural EM symposium, a global EM symposium, and new this year, an ED flow symposium, where everything you need to know about improving patient flow and efficiency in your ED will be revealed. And Jesse McLaren will be offering his advanced ECG interpretation course called Hearts. One of the great things about the EM Cases Summit is the elevated degree of interaction. You can ask any of the speakers any question and get the answers that you need. You can have discussions with other attendees at any time and see other discussions going on. It's the most interactive, large-scale international EM conference in the world. Last year, we had more than 500 attendees. We're hoping to have even a bigger turnout this year to bring the EM community closer together to make our specialty even better. Register July 16th at emcasessummit.com. Well, thank you so much, both of you, for your insights into the wonderful world of subarachnoid hemorrhage. Any last pearls of wisdom, pitfalls, tricks, interesting stories, anything you'd like to add about subarachnoid hemorrhage? Your famous parting words, Dr. Perry? Safe to say, I don't want to embarrass you, but you are the preeminent world researcher on subarachnoid hemorrhage in emergency medicine. So what you says matters. No pressure.
I mean, it's really a question of, again, if the patient appears well, then you're going to apply the Ottawa subarachnoid hemorrhage rule. Think about other diagnoses of the thunderclap headache. So subarachnoid hemorrhage is one of the more common ones we worry about. It's not necessarily the only one we worry about. So you do need to keep your differential broad and make sure you're not closing in too quickly. If the patient's at low risk for subarachnoid hemorrhage, then manage whatever condition it appears to be or symptoms. And be careful when you're managing symptoms to not get lured into thinking that it can't be a subarachnoid hemorrhage because they got better with the anti-migraine treatment that I gave them. While it's true that it's probably more likely that it's a migraine if they got better, it certainly does not exclude subarachnoid hemorrhage. And in our studies, we had several patients with either partial or complete pain relief following NSAIDs or dopamine antagonists, and they end up having a subarachnoid hemorrhage. So don't get lulled into that. And then basically work up using the 6-hour CT rule. If it's less than 6 and they're a normal risk person, stop. If they're a high-risk patient, then you may want to proceed and have a chat with your patient, involve them in the discussions. For most patients, I'd recommend going with the lumbar puncture for the reasons we discussed in part 1. But it isn't a one-size-fits-all situation. You really have to take your patient situation and their presentation into mind and consider what the best next test is, whether it's CT or CTA. If you do go with your CT, to interpret it with, again, as a low-risk tap, less than 2,000, times 10 to the power 6 per liter, or 2,000 when you get your report, with no visible xanthochromia. That's a low-risk tap. So unless your patient's super high risk, you're done as far as subarachnoid hemorrhage goes. If it's clean, you're also done. But if it's a high-risk patient or it's a high-risk tap, then you do need to proceed and get your CTA and come full circle back to the CTA question. If your patient's unstable, time is brain. Don't mess around. That one, you definitely go CT, CTA, and get your friends there early and manage the patient very carefully and very quickly.
Wonderful. I've learned so much about the nuances of subarachnoid hemorrhage, and there were quite a few questions that I had personally that were answered very eloquently by both of you. So thank you for that. Dr. Lin, any last words of wisdom?
Honestly, it is just such a humbling honor to wingwoman Dr. Perry for this episode. And so I completely agree with everything Dr. Perry had mentioned as well. And I think the things that I would highlight and double tap on are, again, for that sick patient who has focal deficits, think about getting your CT and CTA up front right at the beginning. Make sure that for the sick patient, you're considering resuscitation and airway management before sending them out of your department, and focus on the basics and do them really, really well. So your neuroprotective resuscitation, those principles are so important, and they're going to save your patient's life, potentially.
One thing I really enjoyed about this particular series of podcasts is that, again, we have a world-renowned researcher with a few decades of experience as an emergency physician. And then we have, I'm not even going to call you a rising star anymore, Dr. Lin. I'm going to call you a risen star. You have firmly reached stardom with your incredible ability to educate in a clear and concise manner. So again, thank you, both of you. I think that these podcasts worked out really nicely, and I learned a lot. I hope our listeners did too.
Thanks for the opportunity, Anton. This was fantastic.
Yes, thanks very much, Anton. It truly has been a pleasure. And I'm not sure who's the wing person, Dr. Lin, if it's you being your wingman or you being my wing woman. I'm not sure which.
Overwhelming humbleness everywhere.